of Malaya to share with us on artificial nutrition at the end of life. It's a very interesting topic that will benefit us in our daily practice. And the chairperson for today will be Dr. Ellen from Hospital Seberang Jaya. Without further ado, let's welcome Dr. Ellen.
Hello, hi, colleagues, ladies and gentlemen. I'm Alan, your friendly geriatrician from Penang. It gives me great pleasure to introduce Prof. Tan Maupin, a professor in geriatric medicine at the University of Malaysia. This may take some time, so you might want to make a cup of tea or something. She qualified from the University of Nottingham, UK, and later pursued a higher specialist training in geriatric medicine in Newcastle upon time. She worked as a consultant geriatrician at the Royal Victoria Infirmary and Freeman Hospital before returning home to Malaysia. She is the principal investigator of the Transforming Cognitive Frailty into Later Life Self-Sufficiency Ageless program, funded by the Ministry of Higher Education. Prof. Tan is also the honorary secretary of both the Malaysian Society of Geriatric Medicine and the College of Physicians of Malaysia. She is the academic editor to PLOS ONE and associate editor to Frontiers in Medicine. In addition, she has founded the University of Malaysia spin-off Act for Health Sdn Bhd and is the medical director of Genting, not the casino, but the Dementia Care Center and Aged Care Services Sdn Bhd. So you can bet that she is a prolific researcher with 186 publications and almost 1,400 citations. Prof. Tan is one of the most energetic and resilient persons I've ever met. So without further ado, let's welcome Prof. Tan to speak on artificial nutrition at the end of life.
Okay, thanks very much, Alan. I was just telling everyone that I'm actually speaking today with my armor on because this is a very emotive area. To feed someone at the end of life seems like a basic human right, but how we are doing it is actually the question. Okay, so I know I've been told not to talk for more than half an hour, so I try not to make it look too rushed. Okay, oops. Okay, so we are Malaysians. We greet everyone with a greeting, have you eaten? Or sudah makan. So when it comes to not eating, it really upsets all of us. And then towards the end of life, that seems to be, if our relative or loved one is not eating, it can cause a huge amount of anxiety because eating seems to be feeding seems to be now equated to morality and also equated to love and care. Okay, and this is what we normally think when we eat. We have family around us, you know, we have a variety of food, the more the better. And when we eat until we are very, very full, till we are bursting. But the most important things about eating isn't necessarily the calories and the nutrition that we actually put into our bodies. It is actually the social contact. That's the most important thing about eating when it comes to our society. So I'll just switch gears a bit and think about the end of life. So when we talk about the end of life, we need to think, what do we mean by the end of life? Usually, as a geriatrician, I get referred patients that I have to rescue from the jaws of death. And sadly, more often than not, we are successful nowadays. But end of life does not actually mean the last few days of life. It actually usually is taken to mean the period of irreversible decline before death. And if you were looking for a time-based perspective, then some people say it's 6 months of life. But a lot of times when you hear palliative care physicians talk, they actually do ask you to ask that question, whether this patient is going to live, still going to be alive in the next year. But when it comes to definition of end of life, 6 months is by and large what we use, or just irreversible decline before death. We call this the point of no return. Okay, and when someone reaches that point of no return, This is usually what happens. This is common. They don't feel like eating. Yeah. They might be too weak to actually chew their food, swallowing after a little while, too tired to actually consume enough nutritional intake to please their family members. And often conscious level can be reduced. They can sleep a lot, and as the death draws near, they are often in and out of consciousness or totally unconscious for a period, in which case, when you're not conscious, you can't consume. Often, particularly in older people, more and more of our older people now die of dementia or strokes or Parkinson's disease. And these neurological disorders are often linked to swallowing problems, dysphagia. Sometimes it's not difficulty swallowing. Sometimes they just don't want to eat. And we call this food refusal. Sometimes, even if they want to eat, they can't because the gut is not working and it's not digesting the food that they are consuming. So these are the potential solutions that are available to all of us when it comes to addressing these nutritional intake issues towards the end of life. So as a geriatrician, we love this term called masterly inactivity. So in other physicians call it do nothing. But I prefer not to think that I'm doing nothing. I'm making the conscious decision to just sit back and watch and wait. So there are lots of people who make up this world. You know, when some of us, when we're faced with danger, we just rush in and try and save everyone we can without actually taking a step back and having a look at the situation, because without thinking that we might end up having one more person to save. There are other people who do take a step back and look around the room. And that's usually what I teach my medical students. Step back, take a look. And I think that's a basic principle of physical examination. So, and to actually look at the whole situation. In geriatrics, sometimes we go outside the room so that we can actually see what's around. And we can consider this as masterly inactivity, knowing that intervening, doing something might actually cause more harm than actually doing nothing. We could actually give them foods that are going to deliver more calories. And this can be in the form of fortified diets. And our favorite is tau fu fa, ice cream, and then the diabetologist will get cross with us because they say the blood sugar is not so pretty. So I said, why you bother monitoring the blood sugar? Because we are not looking at long-term microvascular complications. Just give the ice cream. Ice cream, tau fu fa, bubur kacang, those sort of very kind of nutrition-packed desserts that Malaysia thrives on, those things are actually can be used as our fortified diets. And older people love them. And the other thing that we love is to actually load them up with calories that tastes of very chemical, like Ensure, like Nutrient Diabetic. I'm not selling them. And they have their role. But if they are filling up on these nutritional supplementation, then it might actually take away the space for something yummy. So we have to be more careful with actually prescribing nutritional supplementation at the end of life. We can do feeding strategies. For someone with dementia, not eating is just because we put them on a bed and we try and get them to eat when they go to bed. To them, they associate bed with sleep. So when they're in bed, they're supposed to sleep. Why are you making me eat in bed? So by taking them out into the living room and putting them around their family and letting them eat normally, eat how they normally eat, they actually eat more. And then The other thing that we can do is swallowing is an issue, or chewing is an issue, is to cut the food up smaller, to mince up the food. We can even puree food, put it in a mold and make it look like a fish, but actually it's pureed fish. So those are feeding strategies that we can try. And sometimes food refusal happens because they've been ill for a while, or someone, God forbid, actually tried MG feed for a while. And then when someone tries to put a spoon or food into their mouth, it tastes awful. They cannot stand the texture. The mouth oral cavity has become overly sensitive. So we get the speech therapist to help us with desensitization so that they can actually eat again by mouth. And of course, the easy route out for us, seemingly in the hospital, is just put a tube in. We just put the tube in and we just feed them the calories. End of story. Don't have to worry. Gut not working, we put in total parenteral nutrition. What's wrong with that? So let me present you a case. So this is a case. All the details have been changed to actually avoid anybody identifying this case. So this is an 88-year-old great-grandmother, and she presented with reduced conscious level, not unusual for our geriatric patients. And then basically, she has had 2 to 3 days of progressive drop in conscious level. For the last 24 hours, she doesn't wake up enough to eat. And she has just been admitted to hospital not so long ago, treated for aspiration pneumonia. They fed her temporarily because conscious level was reduced then as well, but then they removed on discharge and told them to come to feed her at the nursing home. Prior to that, she has had 2 other admissions since October 2019. So we call these frequent flyers, Yeah, so they all get air miles in hospital now. So when on their way to meet their death, they actually collect air miles in hospital. So past medical history, pretty straightforward. Past hypertension, like all of them. And 3 years ago, she was diagnosed as mixed Lewy body vascular dementia at Memory Clinic. And really, because of the Lewy body component, we believe her behavior was quite aggressive. She was wandering at night, and the family just couldn't manage her at home anymore. So they admitted her to a care home 2 years ago. And these are the medications that she takes to try and control her dementia symptoms and also her dry skin. Must be air conditioned in her care home. Okay, so she's a widow. And her husband's a pensioner, which means she gets to stay in a hospital for free, whereas she has to pay in a private nursing home. She was a lifelong housewife, had 1 daughter, 2 grandchildren, and 1 great-grandchild, very, very cute. And her daughter is unfortunately widowed because her husband died before his mother-in-law. Not a surprising thing that we see nowadays. And the daughter is retired. The lady is 88. Now they rely on the grandchildren who run the family business, and now it's MCO, no income. So they have not paid the care home bill for 2 months. So the care home has basically sent her to hospital and say, don't come back because you haven't paid your bill. You cannot come back. Dependent all care, no meaningful communication now for 6 months. On examination, her GCS is not full. Contractures all 4 limbs. Multiple pressure sores, mostly at stage 4. Couldn't hear anything on the chest, just all the rattling that's coming from the mouth. Heart sounds are normal, so no endocarditis or anything, just very stiff, and abdo is non-tender, not constipated. This is what her pressure sores look like. Yeah. This is the sacrum. Yeah. This is, I believe, the elbow. And this is the spine. And this, I believe, is the trochanter. And this is the other elbow. Okay, this is from a nursing home. Yeah, a good one, a private one. On investigation, she had bilateral patchy shadowing, so probably a bit of bronchopneumonia. We did swab her for COVID, it was negative, and blood cultures grew a coagulase negative stuff. We were not too impressed with this blood culture. So we decided to actually give her a bit of oxygen, gave her Ripple mattress, analgesia for her multiple pressure sores, catheterize her because otherwise the urine will contaminate the wound and it can be very painful, but also stops healing. And then, of course, because she was unconscious, she already had an NG tube put in on admission because, you know, the doctor might thought that she must not be starving. And then she was given IV tazocin for her infection. And then her sores were dressed with duoderm dressing. Okay, so after 1 week, GCS didn't change. Yeah. We asked speech therapy, please, can you see if she can eat? Speech therapist says, so drowsy, not obeying commands, nil by mouth, continue NG feeding. And then she completed the tazocin, so we stopped it. I know 1 week, what are we treating? Maybe the chest. So pressure sores looked clean. And then we had to put mid restraints on her to prevent her from dislodging the tube. Okay, what do we do next? What do we do next? Okay, so I'm going to now think about pros and cons of feeding and not feeding. Okay, so let's say to feed, because food is a basic human right now. But complications of tube feeding are numerous, many of which our healthcare profession seems to be oblivious of. Now, the number one cause of delirium is a tube in the nose. You imagine someone sticking in, you've been swabbed enough times, all of you, haven't you? How pleasant was that? Now, imagine that tube sticking through your nose 24/7 until you die. Well, the minute you put that tube in, they will be delirious until you take it out. So it causes delirium and it's uncomfortable. And it looks like an elephant. Yeah, Dr. Yao calls it the belalai. Yeah, so, and then there's no pleasure in life anymore. There's no social eating. I don't get to taste my favorite food, my chicken rice, you know, my soup kambing. I don't get to taste it anymore. And then having a tube in, because it has to be fixed firmly to stop removal, inadvertent removal. Sometimes you actually get pressure sores on the nose. When you put it in, this person isn't going to swallow when you say 1, 2, 3. Yeah. So the nurses are usually the ones put it in. What they do is they will actually elicit the gag reflex and then shove it in as quickly as possible. And then if it goes in the wrong way, sometimes it comes back out the mouth and then they put it in again. Sometimes it takes multiple attempts to get it in. And because they're doing it blind, you have no idea what sort of damage goes down. When you look at the skin already so lousy, you don't know what the skin inside is going to look like. And then they have to be restrained to pull it out, to stop them pulling it out. And then the feed itself is a high osmotic load. We don't drink calories, we eat calories. So the calories sit in the stomach and gradually get digested and released. The nutrients gradually gets released. The feed is not normal. It's a high osmotic load and it causes electrolyte imbalances. And then if you're a diabetic, your blood sugar goes all over the place because we don't have enough kangaroo pumps to give continuous feeding. So what we're doing is we're actually giving bolus feeds. And then when do you give the insulin? 6 times a day? So their blood sugar is all over the places. And then the feed can cause diarrhea because of the high osmotic load, and because they're at the end of their life, the stomach might not be moving properly, so it sits in the stomach. And then of course you displace the tube, and then when you have and then because this feed is liquid and the tube holds open the cardiac valve of the stomach, then feed is likely to track back up the tube and into the lungs and cause aspiration pneumonia. So tube feeding does not prevent aspiration pneumonia. And I will have evidence to you later that in fact, it possibly increases the risk of aspiration pneumonia. We haven't talked about how much it costs yet. Each tin of feed, 80 to 90 ringgit. If you're on full feed, 1 tin lasts 2.5 days. So 1 week, you need 3 tins. So the cost is astronomical, let alone having to replace the tube on a regular basis. And it does not prevent aspiration pneumonia. So why do we tube feed? So we tube feed under normal circumstances when they're not at the end of their lives, so that they have adequate oral intake to maintain nutritional needs. And when you tube feed, you will take away this mechanisms of cleaning your mouth called oral clearance. So when we swallow, we actually clean our mouths and we get rid of all the bacterial colonization. So when you bypass the oral feeding mechanism, what you will do is to actually bypass we actually lead to bacterial colonization of the mouth. And that is the bacteria that they will aspirate into their lungs. And that is what causes aspiration pneumonia, not the food, not the stomach contents. The tube holds open the cardiac valve, as mentioned earlier, and that the feed then refluxes into the lungs. And I mentioned the fact that the feed is liquid and therefore doesn't sit in the stomach. But we forget this. Even though you don't let people put food through your mouth, so you bypass that mechanism, you still provide the saliva. Nobody sucks out your saliva every 2 minutes, right? So that 3 liters of saliva that we produce every day will still go into our lungs. So, and then now you've actually ensured that there's bacteria that goes in with the saliva. So how about not to feed? Okay, food is perhaps a human right. I agree. And I would never deny that. And that's basically, this is a Rome Declaration on Food Security in 1996, which all the heads of states and governments that actually are part of the United Nations say that right of everyone to have access to safe and nutritious food, consistent with the right to adequate food and fundamental right of everyone to be free from hunger. And we know that as a country that has gone through hard times during the Japanese occupation, during the communist occupation, food is very important, which is why we greet everyone by sudah makan. If anyone dare says no to sudah makan, my goodness, the amount of food that's going to come flying your way will be quite frightening. Okay, so how long can someone survive without food? I always ask this question, and you'll be surprised. I never fail to be surprised by the answers I get. But in actual fact, there's very little human studies on how long someone can survive without food. So we have to use some empirical evidence. And the best evidence comes from the Irish hunger strikers. So our colonizers, the British Empire, also colonized the Republic of Ireland, and they jailed these terrorists from these Irish dissidents, and they decided to go on hunger strike, and they let them strike, and they had access to water, but they didn't eat. And the longest one lasted was 73 days, and the shortest was 46 days. So minimum 1.5 months if you were a fit young person, I presume. But then the Irish were never so fit, because they were always starving. So near total starvation with access to water. So in cases of cancer, anorexia nervosa, your BMI has to be about 12 to 12.5 before you die. So this is more scientific evidence. So that's half your normal body weight. You have to lose half your normal body weight before you die. And if we withdraw food or water, we have much more evidence on that based on all the studies that have been done on withdrawal of artificial nutrition and hydration in people with persistent vegetative state. So without access to water or food, you will live for 10 to 14 days. So, but this is the caveat. We said we don't want to tube feed. It does not mean we are not feeding, okay? So even if we decide against tube feeding, food must be offered orally, and it is a basic human right. And internationally, the belief is that artificial nutrition is a form of treatment based on the recommendations of available international guidelines. And the death that occurs is occurring from the underlying illnesses. Starvation might or might not be the mode. I would argue that it isn't, because remember, even in people with anorexia nervosa, you have to lose half your body weight before you die, and rarely do we see any of our patients lose half their body weight. They're dying of the underlying illnesses. And the argument is that whether they have food or not makes no difference to the outcome. So the question is, does extension of life really occur with tube feeding? So sometimes, so it's not so clear cut. Sometimes, even though you have 6 more months to live, you might still need that NG tube, because if we didn't give you that NG tube, then you have less than 6 months to live. And sometimes, yes, you might not make any difference to the length of time you have left, but the tube actually makes it more comfortable. So for instance, if you have bowel obstruction, then you put that tube in, it relieves, it gives you symptomatic relief because you're no longer vomiting all these awful things. That's very straightforward. Sometimes in someone with Parkinson's disease, they need their medications, otherwise they're stiff as a board. So you have to put in that tube to deliver their medications, and they feel better with the tube inside you. Yeah, and sometimes, yes, they've got 6 months left, but you just feel that their swallowing is only temporarily impaired. And so if you give them a feed, if you feed them for a few days, it will recover, and you should be able to, they should actually be able to eat again. So they are at the end of life, but not actively dying, and there's some reversibility. So not so straightforward. This is usually the gray area. And of course, if the patient say, I'm hungry, and they cannot eat enough, then you will give them, you will consider tube feeding. But I have not actually seen that situation. So and then this is an ethical principle that if there's any doubt, because I mentioned that sometimes you just don't know, you just feel like this might be reversible. If there's any doubt, there should be no distinction between not feeding, withholding feeding, or withdrawing feeding. So you shouldn't withhold feeding because it might work. And if withdraw, so it must be okay to take it away again, and there should be no difference between withholding and withdrawing, between giving and taking away. Yeah. So this is actually the current thinking. So let's talk about withholding and withdrawing artificial nutrition. Okay. So this very common term that I have on the top of my patient's bed, nil by mouth. Nil by mouth to me often means never by mouth again. Basically, when basically, if you feed by if you feed by tube, yeah, basically you don't, and not by mouth, you are basically subjecting this person to complications of NG tube. And I'll show you how common those are in a minute. And it could be gut complications because of gastroparesis, metabolic derangement, or aspiration pneumonia. And these muscles that help us swallowing, our muscles of mastication and our muscles of swallowing are all actually skeletal muscles. And we know the principles of deconditioning. So we know that if we put someone to bed and don't let them move, the muscle wastes away. It's no different here. So by not feeding by mouth, what we're actually subjecting the person to is acute sarcopenic dysphagia. And imagine having this tube in, very uncomfortable, see everybody eat, you don't get to eat. So they'll feel, they basically eventually forget what food is like, because a lot of these people already have cognitive impairment. And then eventually when food is introduced, they actually draw back at the sight of food, or draw back at the smell, or the texture, the tastes, because they no longer recognize this taste, or the sensation is now unpleasant. And then the social deprivation, other people have birthday cake, you cannot eat. Yeah, so, and it's very depressing. So when we consider whether we withhold or withdraw feeding, we need to consider patient autonomy. Yeah. So ideally, the patient can make the decision, and we often don't consider that. You can ask the patient whether they would want to be fed. Okay, as long as a person is able to understand the information, retain it for just long enough to weigh up the pros and cons, and to communicate back the decision whether they want feeding or not. Yeah, they don't have to remember the information for that long, only long enough to make the decision and communicate the decision. Sometimes more and more patients might have a written advance directive, and that makes life much, much easier. But more often, patients might have expressed to their family, please, or, sometimes when something happens to a relative or when they see something on television, they might have said to the family, oh, if I reach that stage, please don't feed me through a tube. But quite often, patients would not have left any express wishes, and the family are then the surrogate decision maker. In some countries, there's this thing called the power of attorney, but this has to be an enduring power of attorney. In Malaysia, the power of attorney ceases to function once a person loses mental capacity. So it's not very useful. We need new laws. And in Malaysia, we usually go to the next of kin, to actually make the decision. And it's important that when we ask the next of kin for the decision, you don't say, do you want? You should say, what would your mum or dad have wanted? So what they are supposed to do is to actually communicate what the patient would have wanted. Were they able to make that decision? And then you have the issue with, sometimes you have the issue with no relatives. We have that more and more, and usually it has something to do with the hospital bill. And then the doctor then has to make the decision for the best interest of the patient. We try and draw back from best interest decisions because we don't really know the patient well enough to make best interest decisions. It's best to actually speak to people who know the patients and to make more informed decisions based on what the patient would have wanted. And then, so that was autonomy. But we also need to consider beneficence versus non-maleficence. And I highlighted the maleficence a lot in the risk of complications. So I won't dwell on that anymore. But there's also this issue of medical futility. So the question is, does NG feeding prolong life? Because we know this person is going to die anyway, right? So will it actually do any good? If it's not doing any good, then we shouldn't offer a treatment that is futile. Okay, so there's no beneficence if in the case of medical futility. And I mentioned the deconditioning, the maleficence in terms of by subjecting this person to NG tube, they might never be able to eat again till the day they die. The beneficence might, first of all, appear extension of life, but the extension of life might be outweighed by the quality of life, the extended life. So, if let's say the amount of time the extra time you're giving them means comes with additional suffering, with limited quality of life, it might actually then push you towards maleficence. So it is a very complicated area. How about justice? Okay, so the case I actually brought up brings up the issue of justice. Resources are limited. And sometimes in our country, it's very clear-cut. You will not get social services to fund feeding. They know the issues and not going to do it. Because they're telling you, this person is dying, why should I spend thousands of ringgit every month keeping them alive? They will not give you money for NG feeding. And so in the end, we end up begging and borrowing, finding out who's died and taking the feed away from them to give to this person who's dying. But we need to consider that resources are limited. The other thing is that if the treatment is futile, the family members should not have a right to demand, because most of us work with the public sector in geriatrics, but there are also private sector geriatricians. But even in the private sector, there's only a limited amount of resources, and so patients should not demand treatment, even if it's futile. We don't even need to offer. But if the family are actually demanding feeding, and you feel that feeding is actually futile and therefore you don't want to actually provide it, it's important that they have access to second opinion, or you find another doctor who actually are willing to actually provide it for them. Okay, so this is the evidence I keep hinting to. So a very bright young doctor came to the UMMC several years ago, and she's now a geriatrician in Damansara Specialist Center. Dr. Diana did this study at our geriatric ward. And this is what she found, okay? So she surveyed patients admitted, all patients admitted to the geriatric ward over the period of 6 months. So we had 432 patients. Those days we didn't have that many patients, but nowadays we actually have loads more. So, basically 22% of anyone who actually has been through our ward ends up with an NG feed, okay? This is shocking, isn't it? And out of those 22%, those 96 who ended up with NG feed, only a third of them had NG feeding, were on NG feeding before they turned up in hospital. 2/3 were actually started in hospital. But this is the shocker. This is the shocker. Complications rates of 66%. So 2/3 of our patients who were started on NG end up experiencing at least one complication from NG tube feeding. And the mortality rate from our patients who were NG fed was 38%. And then we had 32% came in, but the ones who, so the net exit with NG tube outnumbered the net intake with NG tube. So a lot of them, actually 60% of those who lived, who lived through this NG tube treatment actually were discharged with an NG tube inside you. But the complication rates actually really, really hurt. So we asked the caregivers, we were able to locate 70 of the caregivers, and we asked them, do you agree with NG feeding? I mean, you would have thought 100% of them agreed because we put it in, right? But we didn't ask. So only 63% agreed in actual fact, but that's still the majority, I suppose. So, and most of them felt that the NG feeding was necessary because they were afraid of death by starvation. Of the 27% of the remaining, the 37% who didn't agree, who didn't agree, the 27 disagreed, and 27% disagreed, and 10% said, don't know whether I want it or not, because they really are not sure. And 58% of those who disagreed said, what for? Doesn't make any difference. And then, in fact, 26%, 1 in 4 of those who disagreed actually said doctors should not interfere with the process of dying. And then only 1%, 5% felt that dignity was important. That hurt too. Okay, so this is a systematic review done by a PhD student that both Sanjeev, Mahadeva, and myself co-supervised. And so we looked at all the literature that has ever been published in the world on barriers and attitudes towards not NG feeding, but PEG feeding. Because if you don't know this, in the developed world, nobody goes on long-term NG feeding. So if someone needs long-term feeding, they have a PEG put in. If you need no self-respecting primary care physician or district nurse would accept someone being discharged to the community with an NG tube. So they all have to have a PEG put in before they leave hospital if they need long-term NG feeding, long-term enteral feeding. So we looked at all the qualitative and quantitative studies, and I just want to share some quotations from the qualitative. So this is picking, okay? So it might be bias sampling. So this is what some of the people said about their PEG feeding. There's no birthday cake, can't have a party. They'll say he'll be 80, but I said, how can we have a party? And then this one, these patients, remember, are not at the end of their lives. These are just people discharged with PEG. Most of them would have had a stroke. So most of them would have more than 6 months to live. You've taken away the pleasure aspect of food. Food then just becomes fuel and not a leisure or pleasure activity. And this other paper said, this quotation we got from this other paper said, we wouldn't have chosen it. They put us through hell about this PEG because we said he wouldn't want this. And they said, the doctor said, are you willing to stand by and watch him starve to death? So finally, let's look at some available international guidelines. Okay, so these are the guidelines that I could find. So that's European guidelines. I like this very much. But the most recent guideline actually released by ASPEN, which is the American Society for Parenteral and Enteral Nutrition. This is the American Palliative Care Association. And then this is the General Medical Council of the UK. It's equivalent of the Malaysian Medical Council. So the ASPEN guidelines, statement 11 says, every individual is entitled to obtain the best care available. Resources have to be distributed fairly without any discrimination. On the other hand, treatments which are futile and do only prolong the suffering or the dying phase have to be avoided. In regard to limited resources, there has to be a proper use of ethically appropriate and transparent criteria. ASPEN 2021 says, AANH, that's assisted artificial nutrition and hydration, neither stops dementia disease progression nor prevents imminent death. And the decision to forego enteral nutrition in end-stage illness is supported by current scientific evidence. For persons at the end of life, the preferences or quality of life goals with acceptance or refusal of modified consistency foods and fluids provided orally or AANH must be respected. Must respect their wishes, autonomy. So this is General Medical Council. The British are a little bit more, a little bit less harsh. So they said, providing nutrition and hydration by tube or drip might provide symptomatic relief or prolong or improve the quality of life of patients, but they may also present problems. The current evidence about the benefits, burdens, and risks of these techniques as patients approach the end of life is not clear-cut, can lead to concerns that patients who are unconscious or semi-conscious may be expressing distressing symptoms and complications, or otherwise be suffering either because of their needs for nutrition or hydration are not being met, or because attempts to meet their perceived needs for nutrition or hydration may be causing them avoidable suffering. So basically, they're sitting on the fence saying that you can give, but giving might cause more suffering. You can also not give, but not giving also might cause more suffering. I don't like that one. Okay, but this is the American Association of Hospice and Palliative Medicine. I think it's what it's called. Yeah, so they say this is the key elements of how you make the decision. ANH, or artificial nutrition and hydration, is a form of medical therapy. Like any other medical interventions, so it needs to be evaluated by weighing its benefits and burdens in the light of the patient's goals of care and social circumstances. Now we know it's medical management. It can be ethically withheld or withdrawn, consistent with the patient's wishes and clinical situation. So this calls for open communications between patients, families, and caregivers to ensure that the concerns are heard. I'm afraid they might starve to death. Well, towards the end of life, it's not starvation that kills them, it's the disease. Yeah, and then respect the patient's preference for treatment once the prognosis and anticipated trajectory with and without ANH have been explained. So autonomy yet again. So where do we go from here? Okay, so really, the problem is best prevented. Yeah. So we want the patient to make the decision before they lose the ability to make decisions. So this, if we could actually get patients to actually do more advanced directives, I can do one now. Why do I have to wait until I have dementia? Or even when we know they're getting dementia, we'll just say, oh, you better leave your wishes, because otherwise they put tubes into you when you don't need it. And then I think we can do is when we know they've got the disease, or even when they've lost capacity, we can make the care planning decisions with them, or we use the surrogate, the family members, so that when they do fall ill, they don't end up being rushed to hospital and being subjected to lots of tubes. And we should actually also get them to leave prior express wishes. If some of them don't want paperwork, nowadays bureaucracy is driving everyone mad. So they might just want to say, it's okay, I just tell my children, I trust that my children will do the right thing. So they might actually just express their wishes, watching television now when they see a family member actually going through this. They might already have left directions to their own family. And then they might actually appoint surrogate decision makers, and they might actually ask or even if they don't, we might identify such surrogate decision makers, but make them consider the patient's wishes. If all that is actually not met, then we often have, we should use an interdisciplinary team. Don't feel tempted to make this decision on your own. Talk to your team and make a team decision, because sometimes it's actually the cleaner who actually has the head screwed on most right. And then the cultural considerations, of course, need to be taken into consideration. There's a lot of religious beliefs in our culture. And if you're not too sure, limited trials are acceptable, but with clear goals. But do remember that depriving someone of oral feeding for even a short period of time might mean that we might never achieve good enough oral feeding after that. So we need to establish wishes as early as possible. Make sure they document and communicate it. Make sure that people know what to expect as the end approaches. So there's a lot of awareness needs to be given out. So death should not be considered taboo, and we should actually get society, we should actually go out and give public talks on death. Because actually the persons who currently find death most taboo are medical practitioners, because we see death as a failure. Well, if 100% of the people in this world have to die, then you have 100% chance of failure. So let's readdress our paradigms in medicine, and let us embrace death as an inevitability. And we need to be one step ahead. We can prevent infections, so they don't have to come to the hospital, and they don't lose their swallow towards the end of life. We vaccinate them, COVID lah, influenza lah, pneumococcal lah, anything available, just give it to them so they don't get those infections as much as possible. We can circumvent swallowing issues by careful hand feeding and maintain hydration by, always reminding them to drink, masking water, H2O, as jelly, so if they eat instead of drink, giving them tasty water instead of water with taste, a bit of lemon and those sort of things, instead of just making them drink plain tap water. And then basically avoid hospitalization by establishing community-based care and hospices, and also establish care planning. So everyone should do this before you reach 50. Make sure you have enough money put aside for your care should you fall ill in the future. And then make sure that if you know that you've got this illness coming, you already plan, identify affordable sources of care. If you don't have enough, save up for it. If you don't have enough money, you need to know where to access all these aids, so that you're not left in the lurch at the very last minute and having to go to hospital because there's nothing else that you can actually do. Hospital should actually be the last port of call for our older people. So if you're interested in those guidelines, these are the links to those guidelines. And that's the end of my talk. Thank you.
So thank you very much, Prof. Tan, for the comprehensive coverage of the topic. I think nowadays we don't ask sudah makan, we ask sudah cucuk. Okay. So there are a couple of questions in the Q&A. Okay, in case you want to ask questions, there's an icon on the right lower part of the Zoom. So under Q&A. First question. Since NG feeding opened the cardiac valves, with that, can PEG tube be a better option in patient not so near end of life?
Yes, it is. And in fact, we actually conducted an intervention study comparing PEG and NG feeding. And PEG tube does not extend life, but it actually reduces complications, because then you don't have the issue of it actually holding open the cardiac valve. And I didn't have time to pack it into this talk, so thanks for asking this question. What we need to consider if let's say we feel that this person should actually still have enteral feeding, if there is likely that they will need long-term enteral feeding for any more than 6 weeks, you should already have put in the PEG as soon as you can. So you don't have to wait to 6 weeks, you put it in week 1.
Another statement or comment from Wong Chi Kong. Dear Prof, it's very interesting. It's a very interesting topic which is rarely discussed. The hunger strike mentioned happened in Northern Ireland prison, and one of the most famous protesters is beneficence. So there's a link in case you want to read about beneficence. The withholding of artificial feeding by order of law can be referred to the case of Terry Schiavo. Yeah, I think this Terry Schiavo is the American case. Yeah, there are many cases. In UK, it's Anthony Bland who had a coma. Another one. In what situations would you withdraw feeding in a vegetative state, i.e. akinetic mutism, but not so near end of life situation?
Oh, yeah.
The thought of withdrawal feeding fasten death and leaving patient dehydrated.
That is so true, and that is something that pains the medical profession a lot, because a lot of times people who are pro euthanasia will turn around to us and say, would it not have been better to end it quicker? Yeah. So but at the moment that's illegal in our country. So there is a difference between persistent vegetative state and akinetic mutism. So the cases of persistent vegetative state are those with basically irreversible brain damage, and therefore they actually the only thing that is working is the brainstem, so they can actually still breathe for themselves, and all the elimination and everything is intact, but they have no consciousness. There are groups of people, we've got one on a ward possibly at the moment, who have apparently unconscious states, and either from catatonic depression or things like that. And those are very difficult, because the question is how reversible it is. So in Malaysia, there's no test cases. So so we don't tend to go down the route of going to court to stop feeding for persistent vegetative state. But in countries like UK and US, you can't do it without a court order. So it's a really, really big thing, and so I don't need to enter into this because we let the courts decide. Then with the catatonic depression and things like that, I guess it would be a case of there's no difference between withholding and withdrawing. If you feel that this is potentially reversible, there would actually be a case to start, knowing that with clear goals in mind. If the goal is not achieved, then to take it away is okay.
Okay, another question from Dr. Vijaya. Good afternoon, Prof. My patient, a 88-year-old, takes only soft diet sparingly. The family is concerned that she refuses to drink fluids. She has underlying vascular dementia, became too quiet when on medication, no clear speech, dependent for ADLs, blood electrolytes normal. What can I advise?
Well, sounds like you're doing very well. Yeah. So she's still eating. Okay. So so basically this has nothing to do with artificial nutrition in actual fact. This is about hydration. And if you were to put a drip into this person, they will pull out the drip, they'll get gram-positive cocci sepsis, and then you'll be visited by the ID team to actually get you to do a root cause analysis. So don't do that. So what you want to do is to actually offer them drinks often, flavor the drinks, because they might not want this drink because it tastes awful to them. So put nice flavor, pandan leaf, and also a bit of rose syrup, bit of honey, those sort of lemon also is very good, refreshing flavors. And then the other thing that we do is we make agar-agar. Yeah, I love my agar-agar. Yeah, so with lots of different flavor, and they will eat the agar-agar, so that lots of fluid, and then that's fine. Yeah, so it's actually, we can make this fun by actually trying different things and then stick to the ones that's like it. You might get bored, but they're not going to get bored. They can have the same thing every day, just giving them the thing they like. Okay, and then should we doing blood tests regular basis? That is a difficult question to answer, because it really depends on you as the physician knowing the patient how long more, and whether you would act on the blood results or not.
Would you consider withdrawing as euthanasia?
Okay, yeah. So if we euthanasia, if you actually didn't allow this person access to food or water, I would believe. But we must remember that when we are withdrawing NG feeding, but we are offering them oral nutrition. Yeah, and we will do our best to make sure that gets in. And so we use fortified diets, social eating, oral desensitization, those sort of things. Yeah, and sometimes we use a bit of a subcutaneous fluid to actually support until they can actually take in enough nutrition orally and by mouth and enough hydration orally. But then as time goes by and they are really actively dying, then it's very clear then that feeding, whether they eat or not, makes no difference. And then in which case, if they don't want to eat, that's fine. Yeah. And it's not euthanasia, they're dying. Yeah. You can't kill someone who is dying, theoretically. Yeah.
Okay. From Poon, how do you deal with those who insist on artificial nutrition on religious ground in spite of clear evidence of medical futility?
Do you really have to ask this question? It is so difficult. And really, it's very difficult because we don't know the patient. And sometimes they insist that the person is still, the person still has a role in life, and only they would know. The person who really knows is the patient, but the patient can't communicate that to you. So if in doubt, you need to err on the treatment side. But a lot of times you can't help but understand that this is actually you can't help but feel that this is actually avoidable. So now in our geriatric clinics, our memory clinics, when we see someone starting to lose ability to walk, we don't wait until the swallowing goes. When we see them starting to become immobile, we see it as a sign that we're reaching end of life already. Yeah, so when the mobility starts going down, then we will actually start talking to the family about advanced care planning. It should have been earlier, but very hard culture. So we already have starting talking to them. Then we will say, this is what happens as swallowing goes. And if you put in a tube, then it might cause more suffering and things like that. This is what you could do. You can make sure they don't go into hospital by trying a bit of jelly, this altered consistency and everything. So you avoid the hospitalization and the loss of swallowing altogether. And then we don't actually ever get into this situation. So this prevention is way better than cure.
One question. What do you recommend for sugar control in elderly inpatients on rice tube feeding?
You know what I'm going to say, right? Take the tube out. Yeah, it's a nightmare. So you must remember that the most dangerous thing that can happen is a hypoglycemic episode. Yeah, so there's no need to maintain good sugar control and take the tube out as soon as possible. Ideally, these people should actually be on continuous feeding on an insulin infusion, but we just don't have those sort of resources.
Can patients on a PEG tube be fed orally?
Yes, definitely. Yeah, so a lot of people now on PEG tube. So I would like to dispense of nil by mouth. Nobody is nil by mouth because, like I said, if you keep them nil by mouth, how are they going to get the swallow back? If you don't walk, it's like you stay in bed, you only walk when you're safe. That doesn't work, does it? Yeah, so you have to actually get them to practice this swallowing. So we should actually be feeding everyone by mouth, limited amount, even with NG tubes in. Yeah, so that they continue to practice their swallowing. And you only supplement, remember the enteral feeding, the objective is not to prevent aspiration pneumonia. It is actually to support their nutritional needs. So if they're able to take enough in by mouth, then the PEG comes out. PEGs can come out when Yeah.
Okay. Oral feeding also associated with aspiration. If without NG, how do you reconcile this?
Oh, okay. The question is, are you more likely to aspirate with or without NG, right? Now the answer is no difference, or maybe you are even more likely to aspirate with NG tube feeding. Does that answer your question?
Yes,
it does not prevent NG aspiration pneumonia. Yeah, not NG feeding. Yeah.
Is advanced directive applicable in Malaysian?
Advanced directives applicable. Okay, so there is no law that make it legally binding for a medical professional to actually adhere to an advanced directive. So if I'm a doctor, I read this document, I don't follow, you cannot take me to court. But I got document law. Should I not follow? Of course I want to follow. So much easier. I don't have to make the decision. Don't have to talk to the family. I just follow the document. Yeah. So yes, it's not legally binding, but it's definitely most medical professionals would want to honor it.
One comment. I think most hospitals didn't practice pack feeding for long-term tube feeding, even for those patients who are not at the end of life. Any way to inform or encourage the doctor involved?
Yeah, can we work together on this? Education, I think, education. Yeah, and we also need more PEG people who are familiar with PEGs, because the thing is they don't like it because they're scared of it, you know. But actually, if you ask patients who have PEGs instead of NG tubing, life is so much better. Life is so much better. So maybe some testimony from the patients with the PEG, you know, they can go out, you know, no belalai. They look normal. And then they can eat also, you know, it's just if not eat enough, then if they cannot manage enough this here, then they can have some here additional extra through their tube. Yeah, so we need more people to come out and give a positive report of PEG. But sometimes from the international literature, unfortunately, as you could gather, sometimes we go the other way. We put in a PEG even when someone is at the end of their life and it wouldn't make any difference. So that is also something that potentially can happen and needs to be avoided.
Okay, one final question on dementia patient. How about those actually don't have, how about those who actually don't have any issue swallowing, but refuse to eat due to dementia and kept spitting out? What is your suggestion for this?
Well, that's tough because it's called food refusal. And to put a tube in those kind of people, you're asking for trouble. They will pull it out and then you tie them up. And then it's like they are masters, escape artists when they will do this, and then it increases their confusion and everything. So so basically food refusal is very, very tricky, but you have to understand that this is part of the dementia syndrome. So we have to try lots of strategies. And one of the most important thing you have to remember is not to make it an issue. Yeah, because the more you concentrate on this issue, you're actually negatively or even positively reinforcing the food refusal. So, but it is not easy to actually deal with. And it is also a sign of the disease. Yes, so patients do die of food refusal. Yeah, but it's the dementia.
One question from our friend from Sabah, Dr. Primala. Decision for artificial nutrition is a dynamic process.
Yes.
As prognostication can be extremely tricky. Some patients appear to be actively dying, but somehow manage to pull through and alter the disease trajectory. In this scenario, the reversal of decision to withhold artificial feeding and initiate artificial nutrition seems appropriate. Do you commonly experience this?
Because we feed, I have to say, because we feed so often in Malaysia, I don't see this scenario that often. I have seen this a couple of times in the UK when, you know, we thought, oh, no hope already. So withhold everything, stop everything, and then they wake up and then they need some nutritional support. But what is very remarkable is what happens a lot more is when I'm on the ward, I will talk to the team and I'll say, you know, this person 6 months left, you know, what's important to him in life, those sort of things. So they go and talk to the family and they ask. Then the decision is, of course, take the tube out, just see whether they eat or not. Just take the tube out. And then they think taking the tube out, the person is going to die. But to the surprise, right? This is like the NG tube is like a sleeping pill because it causes delirium, remember? So you take the tube out, the person opens their eyes, wakes up and starts eating and goes home. Yeah, so because you must remember that instrumentation causes delirium and prolongs delirium. So one of the treatments in geriatric medicine is to remove the tube.
Okay, I think time's up for now. And thanks, Prof, for the very comprehensive coverage and the very interactive audience. Okay, so remember to join us next week. Goodbye.
Thank you, everyone. This week we don't have any QR code, so we will manually key in the CBD points for everyone, and the e-certificate will be sent to your email by the end of this month. Thank you, everyone, for joining the webinar.
Thank you. Thanks for coming. Bye.
Bye.